Glomus tumor. It is the most common benign tumor of the middle ear, mostly seen in the age group between 40 to 50 years, and male to female ratio is 1 to 5, 1 is to 5. That is, females are affected 5 times more than the males. It is non-encapsulated and it has high vascularity. It arises from the dome of the jugular bulb and the promontory of the middle ear. As it arises from the jugular bulb, it invades the hypotympanum. Middle ear cavity below the tympanic membrane is called hypotympanum. It invades hypotympanum and jugular foramen. As a result of the jugular foramen involvement, there is paralysis of 9th to 12th nerve. So there is dysphagia, harshness of voice, and the pharynx involvement, paralysis, vocal cord paralysis, and sternocleidomastoid muscles and trapezius weakness, and atrophy of the tongue, half of the tongue. That is pharynx, vocal cord, trapezius, sternocleidomastoid muscles, and atrophy of half of the tongue. Then coming to promontory, oral symptoms and due to polyp. Oral symptoms are hearing loss and tinnitus. When the tumor is confined only to the middle ear. Polyp, when the tumor enters into the external ear through the perforating through the tympanic membrane, these symptoms are seen. These symptoms are more common: hearing loss and tinnitus. And on observation, tympanic membrane shows a red reflex and a rising sun-like sign. This is rising sun sign. It is when the tumor enters the external ear through the floor. This gives appearance of rising sun. Coming to the polyp. When tumor presents as a polyp, there is hearing loss plus tinnitus. Along with that, dizziness and otorrhea. Otorrhea is due to secondary infections. And earache is less common in this, so that it can be differentiated from the carcinoma of the external and middle ear where there is severe earache. Along with that, there is bleeding. As I already told, it is very highly vascular, so bleeding occurs spontaneously. Diagnosis: CT to distinguish between the glomus jugulare and the glomus tympanicum. This is glomus tympanicum. And MRI to know the extent of the tumor, and angiography to know the feeding vessels, and embolization technique to decrease the blood loss during the surgery. It is done 1 to 2 days before the surgery. And brain perfusion and the flow. Brain perfusion and flow. This is necessary because when tumor is pressing on the internal carotid artery, if the case needs surgery, brain perfusion of the contralateral internal carotid artery can be assessed, so that we can know the risk of the stroke and the need for surgical replacement of internal carotid artery. And coming to the treatment, it is by surgical approach, radiation and embolization, and combination of all this. Radiation and embolization are to decrease the vascularity of the tumor. Surgical approach is through transcanal approach. If the entire circumference of the tumor are clearly visible. Then comes hypotympanic approach, when the tumor involvement is in hypotympanum but mastoid is not involved. Then comes facial recess approach, when mastoid is involved but jugular bulb is not involved. Next, mastoid neck approach. It is done to the tumors not extending to internal carotid artery. Then Infratemporal fossa approach, when there are large glomus jugular tumors. Transcondylar approach, if the tumors are extending towards the foramen magnum. I repeat, glomus tumor is a benign tumor and non-encapsulated and vascular. It arises from jugular bulb and promontory. As a result, there are oral symptoms as well as jugular foramen symptoms, that is cranial nerve paralysis, hearing loss, tinnitus, and rising sun appearance. And there is also a pulsatile sign, that is uh, when ear canal pressure is raised with serous speculum, the tumor pulsates vigorously. And the reverse happens when we release the pressure. On applying pressure on the ear canal, the tumor pulsates vigorously. And coming to polyp, hearing loss, tinnitus, dizziness, and otorrhea, and bleeding. And diagnosis by CT, MRI, angiography, embolization, brain perfusion, and flow studies. And treatment by surgical, radiation, and embolization. Surgical through transcanal, when entire circumference of tumor is visible. Coming to hypotympanic, when hypotymphanum is involved, mastoid not involved. Facial recess, mastoid involved but jugular bulb not involved. Mastoid neck, when internal carotid artery is not involved. Infratemporal fossa approach, when there are large glomus jugular tumors. Transcondylar, when the tumor extends to foramen magnum. Thank you.